So now we're going to have a panel debate, and I just want to start with saying that for me, one of the most amazing things that's been said here today over and over again is that we actually now have this window of opportunity, that there is a real chance of actually ending the AIDS pandemic if everyone works together and with full strength. And I've done, as I told you during the day, I've done so many stories on HIV AIDS. I've visited villages in Malawi where a generation is missing. The generation was supposed to work, the ones that were going to cultivate the land. And I mean, you all seen this as well, but I've visited the child-headed households, meeting the children who have no adult relative alive anymore and are just left for themselves. And I think that if we have a real opportunity now to do something that will end this for the future, it's amazing. And therefore I want to start to ask you in the panel to talk about what is needed to change to actually reach the goal, because the way the curves that we've been looking at now, they have been going in the right direction, but if I haven't misunderstood everything, some things actually looks like if they're starting to go a little bit, indicating that they might be going the wrong way again. And what do we need to change to keep it the right way and to reach the 90-90-90 goal that we have been talking about? So I would like each of you to talk 2-3 minutes briefly on this. What needs to change to reach the goal? And I want to start with Sibongile.
I think we need to change the way of reporting our data and the accountability, especially with government officials. We need accountability. You know, it will assist the information to flow down to communities, and it will assist civil society to be able to respond in some issues, and it will assist the government to know where to tackle the issues. And we need to change the way ARV supply it's been done. Recently in South Africa, for a few months we've been seeing a shortage of alluvia, and this it was because of alluvia. It's only distributed by one company, of which it's patented, and it's been given a license of 20 years, of which it will be ending by 2020. So any other companies, they cannot make generic alluvia to be available in the country. And when this one supply is in shortage of medication, then the whole country struggles to access one medication. So the change of doing things, I think it will assist us to reach the 1990 goals.
Thank you. Dr. Michael Johnson from the Global Fund. No, I don't think it's on.
I think you have to
sit.
This one. This one.
Can I do it? Yeah. Okay. Okay. Simple question.
You're supposed to have the answer.
Yeah. Right. I guess. I mean, I think the things that are needed have been said today, and I think that's why I emphasized when I spoke earlier what a exciting and fantastic collection of discussions and presentations. I guess if I'm sort of stepping back and saying, okay, out of all these really big things, what comes to mind? Clearly the funding, so the advocacy piece has to be there. I would boil it down to 3 key things. I'd say the advocacy and the funding to get the resources there. I would say we've talked a lot today about what one might call resilient and sustainable health systems, sort of in relation to the medical model. We've talked a lot about that the traditional medical model is not one that's built for this kind of service delivery. And so we need to be, again, we heard today about changing the ways of follow-up, changing the engagement with communities, collecting and using data locally, those sort of things. And then the third is related to that last point. What you just said is, I think that there's such a history that is so difficult to overcome of collecting data and not using it. And so last session we had a discussion about how much should there be, and should we collect too much, too little. I think it's, what do we use? You know, what do we actually use for transparency, for accountability, for communities and service providers to be able to know how to find those efficiencies and target the program. So in summary, I guess I'd say funding, the new models of delivery and community engagement in that, and data and accountability. And I guess and you have to put in human rights, because of the stigma issues are overwhelming and will always get in the way until we make progress on that. So.
Thank you. Engstrand from Sida.
Thank you. Okay, so I have also written down 3 issues, not to duplicate what has already been said. I think, of course, the first one, there will be a duplication from all of us, I'm sure. That is to maintain funding levels. To get the best possible funding over the next 5 years, that's absolutely essential. Related to that is, of course, the fact that I see that the Global Fund and UNAIDS have really moved in the right directions over the last years. We are seeing the Global Fund being much more active in the area of human rights, really putting funding into human rights programming, which is essential. Much larger focus also on gender equality within the Global Fund funded programs, so that's good. In terms of UNAIDS, I think we also saw the new strategy, which now includes a heavier focus on prevention. The release of the 1990 was extremely important, I think, and from the Swedish perspective, but at the same time, I and many more were a bit concerned that they didn't release anything like that for prevention. So I think the new strategy is absolutely right and doing the right thing just now. So funding, maintain the funding. The second one is comparative advantages. I think we can improve efficiencies, not least the multilaterals. There is a lot of duplication from the UN agencies, and there can be efficiency gains by having better coordination at country level, who does what, and really letting the actors do what they are good at. And the last one is around gender equality and focusing on adolescents. Those are the young generation, the window of opportunity. We have to improve gender equality among young boys and young women. That's the way to go.
Thank you. Marc Biot from MSF.
Yeah, just maybe saying the same, but from the other angle. I think key into that, and what we learned in the now 1.5 decades of HIV fight, is to really looking at this chronic treatment from a patient perspective. I think if we can achieve that, then we'll tackle most issues, for the ultimate goal is that the patients adhere and are remaining undetectable. Otherwise, remaining undetectable is the key condition to get this epidemic down, because by this we will decrease the spreading of the virus. So basically, when you see the difficulties that are encountered by governments, too much still systems are analyzed top-down or only for systemic problems by the managers, how to improve the life of the managers, how much it costs to the system, to the managers, how should they be able to have a bigger efficiency, and we forgot the patient perspective. I'm thinking about the stockouts, what we recently spoke about, and we are coming with a report now on ICASA from tomorrow onwards, by which we realize that basically, we have a kind of good overview and of its stockouts until the district level. But we forget that we in fact usually don't have, or very rarely have, information on the last mile. How many of the patients do access treatment? Just because maybe there is no car going from the district warehouse to the health center. The drugs are in the district, but they didn't reach the health center. Looking at the patient perspective, how to access treatment, how to adhere on treatment will help us, like it was happily said today already, to have a tiered approach, to have a differentiated approach according to the conditions. If you're an intellectual city dweller, and of course you need to adhere differently, and you will adhere differently as compared to a laborer or a farmer far away in a peripheral district. Let's adapt, let's de-standardize our approach according to the reality of the patient, and usually as well on the lowest level nurse. This will help you to understand that we shouldn't ask her half of her time to fill in data, but keep on the focus on the quality care. But of course we need some data, more often even not so much for system management issue, but for her to understand where she is, what the quality she's providing, he or she is providing, and what she has to focus on as a priority for the next month. So I think keeping that eye on, challenging the drives for efficiency, for coverage, by looking at to the quality and the patient perspective will help us forward.
Thank you. And Anna-Mia? Sorry.
I think so I agree, of course, with all of the previous speakers. But to add then, if we look at these three, 90-90-90, the first one is to have 90% of those living with HIV knowing their status. And this is where we fall short. This is our main, shortcoming, because we only have 20 out of the 37 million people living with HIV knowing their status. And obviously that's the main barrier, since we know we can't reach the treatment. Prevention only works if everyone's on treatment, sort of. And we know that more than half of those who are newly infected are infected by somebody who doesn't know they're HIV positive or who are recently infected. And that's the problem. You can never reach those who are recently infected in the last 2-3 weeks. We can never reach them with treatment as prevention, because they haven't. So we need to also talk about prevention, what Pia mentions, and risk behaviors, obviously, especially among in the areas where people are most affected, is among young women. So we need to talk about that too. So I would like the 90-90-90 also in terms of prevention, some sort of similar strategy for prevention, because treatment is prevention is important and extremely good for stigma, because it gives people an incentive to go get tested, that we have this fantastic treatment. But it's not a magic bullet, and we need to remember that most people are infected in a window that's not covered by that strategy. So that's what I thought was important. And therefore, reaching out with testing in terms of community-based testing, household testing, self-testing, adolescent adapted, attractive, like the outreach testing tracks, is so important. And also because it creates awareness. And even if knowing that you're HIV negative is extremely important too, because then you get feedback. Okay, maybe I've been doing something right, or maybe I've just been lucky. And sort of, how do I protect myself and keep myself negative? We did a household qualitative study among household in a community-based household testing in KwaZulu-Natal, and it turned out that those who were concurrently negative, that was also a very positive feedback. Okay, we're in this now, and we can support each other to remain negative. Those were concurrent couples that were concurrently positive, also sort of stuck together. We're in this together. But where the man was positive, the woman would usually stick with him, even if she was negative, to support her. But in couples where the woman was positive and the man was negative, it was even hard to find these couples, because when they had found out that they were discordant, they were HIV discordant, but the woman was positive, they would split up. So this is, the woman, you shoot the messenger, sort of the one who first tests positive. You sort of assume, there was this general assumption that you've been recently infected also, that you've been unfaithful in your current relationship, which is usually not the case, So sort of the idea that if the man is negative, it means that the positive woman must have been recently infected. And that, because they sort of thought that the risk of infection transmission was so high, but we know that people can live together for years without, infecting your partners if you have a viral load, even if you're not on treatment. So I think that sort of these misconceptions are dangerous, because they put the blame on the positive partner in terms of unfaithfulness, and it prevents people from testing together. Couple testing is a complete failure, for example. Really, it really doesn't work. I think very few would go and test with your partner, even among. I'm a highly educated, well-paid woman that I can survive without my husband's financial support, and I can support my children. But for many women, that's not the case. But even I wouldn't go test with my partner. You know, I would like to find out myself first and deal with it myself. And we have this sort of very romanticized fairy tale idea that couples will always stick together, that you only have one partner, only one choice, you stick together no matter what. It's complete bullshit. You know, the world doesn't work like that, not even in Hollywood movies. I think we need to sort of adapt our policies to reality, and for some people it might work, for most people it don't work.
Thank you. And for you who've been working like from the researcher perspective, but also been on the field, like we saw your slide on 2 teen track before, what would you say? What would you like to see NGOs or donors or like the Global Fund? Are there anything that you would say, well, approach from this side as well, like stop the fairy tale Hollywood thing, or like... Do you have some advice?
I think you need an incentive to test, really, you know, and now we have the treatment, which is good. It is not the death sentence to test, because then obviously very few wanted to get that death sentence and live with that. Now at least you can offer treatment, but I think to come out with the fact that treatment is so good, I've mentioned that before, it's extremely important to reduce stigma. And it's like a chronic condition, like any other condition, I think is important. I would rather be, if the stigma was not there, if it was only for medical reasons, I would much rather be living with HIV than with diabetes, for example, because medically it's much more beneficial. The prognosis is much better. The medication is much better and much easier. So it's all about stigma, really. It's all about lack of knowledge. And Kerstin told me that she challenged me that I said the medical thing is solved. I actually said that, you know, for first, that it's difficult and very expensive to access second and third line treatment in low and middle income settings, and that is a big problem still, because the drugs, even the first line drugs, are way too expensive for most governments to be able to afford themselves. So that is really an issue that we need to deal with, and I think it's mainly through primary prevention to prevent resistance from happening, even by supporting adherence, because you can have a little resistance and still the first line drugs work. I have many patients with, you know, they're resistant. Most of my patients have some sort of drug resistance, but it's minor. It's not that important. You know, it's not like either or, black or white. If you have drug resistance, the medicines don't work. They still work, you know, to good enough.
If you get it, I guess. I think Pia was first, because we also heard Sibongile talking about the lack of medicines right now in South Africa. Pia.
One thing that I would like to see being scaled up is use-friendly services that we haven't talked very much about here today, unfortunately, but one thing that we see now is that comprehensive sexuality education is actually now moving into schools again. After a number of years with the PEPFAR, the first PEPFAR program, there were substantial changes being made at curricula in many African countries, unfortunately. And what used to be sexuality education, life skills education, seemed to dwindle away, and that was very unfortunate, because that's needed, of course. And now there is increased interest from ministries of education, ministries of health, to really see that change and comprehensive sexuality education coming back to schools in African countries. So that's a good thing. But the next step will then be to link that education to services as well, because without that link, it's difficult. Young people need also to be referred and know where to access contraceptives, condoms, more education, more support around HIV, for example. So,
and how to do that? How to strengthen that link, would you say?
Again, it's a question about policies being in place to allow for those centers or teenage clubs or whatever we call them to exist. It's also a behavior change, attitudinal change of parents, not least, who many times are not so positive to their young, to their children and youth accessing those services. So that requires a lot of changes at many different levels at the same time, but I'm positive that it's moving now. The sexuality education in schools is the first step.
Thank you. Marc? I think.
Oh, yeah, no,
yeah,
sorry.
you-
So as my neighbor here started to say a bit some controversial, not controversial, but maybe some stronger words on some topics, I would like also to be a bit stronger on some points or less diplomatic. I think we are also fooling ourselves into accepting that with the Sustainable Development Goals, health will be addressed and HIV will be addressed correctly throughout all the different chapters of the Sustainable Development Goals. Streamlining HIV services will kill the advances that we have had up to now. It's just too early. It's just too early. Councillors are, I think, in one country, except one country, they are not yet established as a government worker in most MOHs. Civil society is very weak because they still are depending too much on donor money. And now that the donors are withdrawing, we don't see the government starting to pay for them. Why would they pay for them? They have so many costs for maintaining their system upright. And potentially these civil society organizations might be politically different, have a different opinion on healthcare and maybe make a difference during the next elections. So, and also the distribution systems are much too weak as well. So basically for me, it's somewhere just too early. We have made substantial changes and wins, but the system is not ready yet to already now start being weaned off. And I think I'm very concerned. I'm a usually over-optimistic person, but I'm just very much concerned that we are going to see a withdrawal from all the gains very quickly because we are putting it now in a different financing support system by which there are no watchdogs or critical conditions that will oblige countries to keep in mind these critical enablers.
Michael from the Global Fund, you're getting most of the money to the Global Fund, to Better AIDS. What do you say? Do you agree with Marc?
Yes and no. I guess what I would say is, yes, we have to keep a focus. Yes, I mean, for example, it came up a lot today, which I thought was totally appropriate. I can't remember which presentation. There's so many good ones, but it was around geographic prioritization, intervention prioritization, making sure the resources go where the epidemic is, make sure it's focused and we stay on it. And so from that point of view, I completely agree. I guess the part I would moderate a little bit or broaden a bit is we do have to figure out how these vertical programs integrate and interdigitate, not to the point of losing focus, but we have to figure out how we create synergies, because all of these things we just talked about around data, around community models of care, around all these things are entirely applicable for other areas too. And so we have to figure out how to strike that balance. And I don't know what that balance is, but that's, so we put out a position paper, if you'd call that, or a policy paper, I don't know what you call it, on resilient and sustainable systems for health. It came out in the summer, and it is, it highlights some of these areas that we think need to be in place. The Global Fund doesn't invest in all of them primarily, others do, but we need to be working with the others that are concerned about the systems for health.
Thank you. Sibongile, what do you think? You speak about the situation on the ground, about lack of medicines, about governments not doing enough, or the South African government not doing enough. I should also say that MSF has been struggling to get a representative from the South African government here, also through video link, but it was not possible due to the INCASA and the International AIDS Day tomorrow and so on. But what would you say? What kind of actions would you like to see from?
Yeah, as other speakers have said, testing remains essential for our AIDS response, and it's important to include a testing in the 1990 strategy, because while we are testing, you'll be able to get more people who will know their status. And as we know that tomorrow they'll be announcing the rollout of ARVs to everyone who's HIV positive, irrespective of CD4 count. But then we are still worried as a civil society, if we have stockouts now, what plan the government have in place to to maintain the people who are on ARVs to be on treatment or to adhere, because we have these goals that as South Africa we have agreed that we are going with like the 1990 strategy. But if we continue to have stockouts like we do have stockouts of alluvia, and people were taken back to first line regimen, while some of them they have drug resistance because regimen 1 was not responding to their immune system. So those people, it was like they were given water instead of given essential medicine that is right for their immune system. And on the issue of the statistics, you know, the data and accountability, you know, I would like to stress that, because we feel that detailed information and numbers will help us to know how many people are being tested and the percentage of people who are in treatment. And if I'm not mistaken, it was Anamaya who talked about the linkage between the people who tested and who are on treatment. We in South Africa we are losing people in between. As I've said earlier, that in Gauteng we lost 30% of people who were taking. Yes, 30%. In Gauteng, in province alone. So, of which that means there is something that is not right, and we cannot follow up these people, because some of them, because of stigma and discrimination, they are given out wrong address, and because of demarcation, you know, there's this thing of demarcation in our country where you have to access a treatment nearer to your area, while people don't feel like going there because a lot of neighbors are going there in that clinic. So because of stigma, a person would prefer to go to another clinic which is far away, and that will compromise the patient again, because that patient, if she doesn't have money to go to that clinic, she won't be able to go. If maybe that person is not working, she'll only prioritize to take that money and buy bread or a meal for kids instead of going to take treatment. So that takes me to the issue of lay councillors, of which as an organization we feel that phasing out of lay councillors, it will be problematic in our country, because these lay councillors are doing a great job of taking medication to the people and to follow up patients at their homes, and sometimes they go extra mile by giving something out of their own pocket with the little money that they are earning to give that to that patient. So if lay councillors are taken out of the system, then it will mean we won't reach the 1990 strategy by 2020, and we won't be able to reach the to end AIDS by 2030.
And we saw in the film here just before the break how several people were telling how they wouldn't have taken their medicine if they hadn't had the support from the lay councillors. But we also hear now that South African government is cutting down on the Monday on funding for the lay councillors. Just briefly, what would you like to see from the rest of the international community, from donors, Global Fund, NGOs? What can be done to change that support approach from the South African government?
I would like to see everyone in the world to supporting lay councillors. We have a case in Free State of which all 179 lay councillors were phased out, were retrenched from their work, and because of that, they had a civil disobedience action outside of the offices, MEC's offices, and they were all arrested for fighting their rights. And we lost the case because Treatment Action Campaign Section 27, as MSF and other partners, we are on this assisting these community healthcare workers. And we lost the case recently at court because the government, you know, politician and some juridical system, they have that interrelationship. Or so we lost that case. But then we are taking case forward. We are appealing to the High Court, you know, Bloemfontein High Court, of which we we think there we will manage to win that, because these people, they haven't violated any person's rights. They haven't vandalized anything. They were just there to demand their work back, because some of them, they were being volunteers for almost 15 years and without earning anything. Now, because the government is phasing out these old lay councillors, they want to do a cadre deployment, of which they want people with qualifications to come and work as lay councillors in some areas. That will compromise the work. And how about these women who are working, or men who are working unpaid, assisting communities? Now they are taken out because they don't have metric. You know, they want qualifications now, of which some people will come with no passion of this work. At the end of the day, we'll see more people dying of HIV and AIDS.
Thank you. Michael, what is the Global Fund's approach to the system of lay workers, lay councillors? Do you work with that at all? Could you work with it? Is that an option?
Yes, there are many countries that do. The Global Fund receives applications from countries that stress their priorities. So we don't have a quota or a mandate to do one or the other, as long as it passes the review of the technical review panel and the grant approvals committee. But having said that, there is very substantial investment, and I should remember the number, but I can't. But it's within the range of things that are health systems investments. It's the second largest, I think. And so there are a lot of countries that have proposed that. It's crucially important, and at the same time, the whole area of human resources for health is to be frank, it's a scary one, because there's such great needs out there. And the entire Global Fund could be about supporting human resources. And that's something obviously we can't do, but we need to figure out how to do that with partners, with host governments, with co-investments, et cetera. So we're hugely supportive, and we have it in a lot of the grants that the countries have approved.
Thank you. Marc?
Building on that, so we had in April this year a big meeting with 7 countries meeting, sending their MOH, Ministry of Health representatives, and joining with World Bank responsibles, Global Fund responsible, and a few other donors. And basically, yeah, we addressed this issue about the councillors. And I think now we won that battle now after 15 years, I think, and myself having been engaged heavily in Mozambique to try to convince governments that they need other people than only purely medically technical trained people. The acceptance is there. The recognition is there. The problem is that they are not integrated within the payroll, or they are not integrated within the system of the ministries of health. Then when you come to that point, you address the issue with the ministries, and they say, yeah, but we don't have enough money, we don't receive enough money, or there are ceiling caps above the number of people we can recruit in official statements, and that's in official positions, and that's due to then Ministry of Finance obligations towards IMF. IMF is approached, and IMF says clearly these ceiling caps don't exist anymore since 2005, so we should not anymore imply them, but they have trained everybody to use these ceiling caps to impose limitations on the human resources they use within the public systems, be it health, be it agriculture, and so on. So I think in there, then we really have a kind of, again, this vicious circle by which we need to give an empowered Ministry of Health to be able to ask for their rights, to have the necessary workforce. In Mozambique, for example, it's current practice that people start in the Ministry of Health as a secretary, as an administrative responsible, earning little but getting experience. And after 2-3 years of public service as an administrator in Ministry of Health, for example, they can apply for the same job in the Ministry of Finance and get double of the salary. So basically, it's the empowerment of the Ministry of Health as well that prevents Ministry of Health for asking for the human resources they really need. Approaching then the donors and then asking them, okay, but what about you? You can't deny the quality of the impact on the quality that the councillors may introduce and bring into treatment when people are empowered and educated. And they will say, yes, fine, but show us now the costing evidence. And this is where then I start feeling frustrated. Because somewhere, do we again, okay, economy and is a reality, and we need to somewhere live into a resource, how limited world. But on the other hand, I think also, and that's why I think as NGOs and as medical professionals, we need first to look into and put central the needs, the demands, and then basically address these issues according to what we need, not according to what we have in the pockets.
Thank you. Pia, you told us before how you cannot do bilateral agreements with South Africa due to. But what do you think? What about the system with lay councillors, and how does Sida work with that, or if at all, or with organizations?
I can't really say very much about it. I'm not into that level. You know, we support MSF, we support other partner organizations who for sure works with lay councillors, but I mean, we're coming from another level.
Yeah. But you heard about it today, and you understand also, I guess, the problem when we hear Siliva telling us how the numbers of lay councillors decreases in the worst affected area of HIV/AIDS in the world.
Absolutely, and as other speakers have said, the challenge when it comes to human resources in health is enormous. And from our perspective, we hear a lot about task shifting, but as Anna-Mia said, I think it's sometimes talk about, you know, just dumping work at somebody else. It's really, there are important cases that have worked very well when it comes to task shifting. Midwifery, for example, taking on important job that medical doctors previously had to do, and so on. But it really has to be evidence-based and really worked through how you will do it. One other thing that I wanted to comment on is the importance of strong ministries of health that you talked about. I think two countries that have done very well over the last years when it comes to improving the health of their people are Ethiopia and Rwanda. Two examples where the ministries of health are extremely strong, and they have known what they wanted, and they have demanded things from the Global Fund and other donors. They have been in charge. They have said, we want funding for this. You know, I think you can correct me, but they were one of the first countries to tell the Global Fund that we want funding for our health sector plan in general, not AIDS specific, you know. And those are the examples that we have to bear in mind and really support the ministries of health to be in charge. And somebody asked me about donor requirements on reporting and data. And I don't want to be bragging, but Sweden and Sida always have the preferred mode of support to a partner is core support. We want to support an organization's entire plan strategy, and we don't want to support on a project basis asking for specific project reporting data, just to emphasize that.
Thank you. I also want to ask if there are any questions among you. We have a few minutes for questions, if there are some. Or if there are, please interfere. Is there anything else that you want to... Yep, Anna-Mia?
Because as you said, donors have requests in terms of reporting on how the money is used, but I think donors could also, and also the Global Fund could demand sort of that governments use evidence-based decision making in terms of how they consider their human resources. And I'm thinking that it is actually now studies are coming out showing that, for example, community health workers could do 80% of what PMTCT nurses do. There is evidence that outcomes aren't compromised when community health workers do counseling and testing. There is evidence now that, you know, that this is also cost effective. So, and I think Ethiopia, for example, is emphasizing that they want to make evidence-based decisions. While South Africa, obviously, when cutting down on the lay councillors, are going the other way. They're doing the opposite. They're not using the evidence that is there, that this is both cost effective and doesn't compromise outcomes. So if you claim that people need to be trained and have, you know, from formal credentials to do this sort of work, you're not using the evidence that is out there. And I think that is quite serious. Donors should be concerned about that. That government, they're funding governments or organizations that aren't using evidence for evidence-based, you know, and research that is out there for decision making, and that is quite serious, actually, that's accepted at all. And so the civil movement should also protest against that. So the South African government, you're not using the evidence that is there. You're making decisions based on what, you know, ideas that aren't based in research, and that's very serious. Public funding is used the wrong way.
Should we demand more of the middle-income countries' governments?
Definitely.
Yeah. Marc?
Yes, we should certainly demand more, but also with, how would I say, taking into consideration what the population can pay for. So not only looking at the macroeconomic conditions of a country, just like Mozambique is going to, in 1 or 2 years' time, probably to also become a middle-income country, but the population's economic reality didn't change since the end of the Civil War. So no, that's maybe exaggerating, but maybe at least in the beginning of the 2000s. So, but then in that sense, I think if it is not linked to, how would I say, internal, well, I think it was said this morning, the taxpayers' redistribution and the capacity of the people to pay, I'm afraid that we will fool each other again with macroeconomic reality and not with population's capacity to pay for services.
Thank you. Pia, should we demand more from the middle-income countries' governments in this?
I think...
Please use the microphone.
Yes, I would say so.
Are you willing to do that?
Yes. If I am willing, or if Sida is willing, I think Sweden and Sida have a responsibility wherever we are active through our partners to be informed, to stay informed about what works, as you're saying, what is evidence, if is evidence-based in programming. If not, of course, we have to ask questions. But then also, I mean, we have to accept our role and really play our utmost role where we are most active and where we have most funding. So, for example, at the bilateral level, national level, in our partner countries, that's where we have most staffing, most resources, and that is where most of our dialogue takes place.
Michael?
Well, I guess I would divide that into financing and policy. They're two related things, but not exactly the same. And the Global Fund has a very aggressive counterpart financing policy that has raised upwards of $200 million in addition to what had been raised before through that mechanism. And the strategy committee and the board are still deliberating on what the new allocation model will look like, but I would imagine that will be something that gets emphasized. From a policy perspective, we certainly, as was said, need to respect and follow the closest science, and the TRP, the Technical Review Panel, and the GAC, the Grant Approvals Committee, aim to do that. There's a lot of gray zone. You know, there's a lot of situations where it's not clearly against it, not clearly with, and so that's where we need partners. We need partners to come to the table and work with us. This is an HIV crowd, but we've had a great deal of success in Eastern Europe recently working on TB hospitalization rates, where tuberculosis patients were routinely hospitalized due to local economic benefits to that and systems. And in a couple of countries, that's significantly changing. Then we didn't do that alone. That was a mobilization of partnerships to engage with the government. And then the last point is one that was discussed today, I think it's a challenge for all of us, is there are more poor people in middle income countries than there are in poor countries. And there's more HIV, TB, and malaria in those places as a major emerging trend. So it's a challenge to deal more rigidly with those countries because the people who get hurt are the most vulnerable in those countries. And so it's a challenge.
Yeah. Sibongile?
So it's a yes and no answer again.
Very diplomatic.
Yeah, I will say yes. It should be increased, especially as Marc has said, that a country mustn't be determined by that the country is a middle income country or what, because at the end of the day, poor people are suffering and they can't access medication or other services that they need. As we speak now, treatment action campaign we were facing closure because of the status of the country, that it's a middle income country and we can't access funding from other countries. And organization like us, we are not taking money directly from government because we feel that if we take money from the government, it will decrease our independence, you know, because we won't be able to voice out whatever we want to voice out in the country, and we won't be able to criticize that we need to be to criticize. So we are not taking money from government, we are not taking money from pharmaceutical companies, and we are very choosy when it comes to funding. We evaluate our campaigns. Recently, we denied money, although we don't have money, but we denied money from a mining company because of our issues on TB in mines. So we don't want to be fed by the donors that will be able to shut our mouth, because we believe that you can't bite the hand that feeds you. So in that case, we cannot take money from government, and we cannot take money from pharmaceutical companies, and they are willing to give us money. Last year on our crowdfunding, pharmaceutical companies came out and said, here's the money, take the money. But because we know our objective, we couldn't. Even medical aids, we can't take money from medical aids because poor people are suffering while they are taking money from people, and people ended up suffering. So we cannot take money from those people. So I will take this opportunity and appeal to donors here in the room and outside of the room to come out and support TAC. Stephen Lewis last week just donated $1 million to TAC, of which it's not enough, but it will make difference. Thank you.
Thank you. And we will very short have a reflection from PehrOlov Pehrson, but I would just like all 5 of you in the panel to very briefly, like maximum a minute, just to tell us what will you bring home with you from today's seminar. We can start with Adamia.
I think
if someone wants to send the microphone.
My voice is very loud. My husband keeps telling me that.
Yeah, but for the people on the web,
I don't know if I know that. No, I think one important thing is that many things, sort of the victories, we've won the fight against HIV, so donors are sort of moving away, and the focus in media and the global agendas is moving away from HIV. I think that's a huge problem. It's partly the UNAIDS emphasis on success stories, consistently pumping out success stories, and that's important in a way to show that it's possible, but it's also important to give this more complex picture of where we have shortfalls and difficulties and complexities, and give this reality check also, because we're at risk of seeing that we already see that funding is reducing, and this is now a window of opportunity to really make a difference and make a dent in the epidemic. But then we need more funding and more focus rather than the opposite. So I see a risk there, and I hope that World AIDS Day and events like this can bring back the focus on that we're this close to, we're in the semi-finals. We can't stop now because we won't reach the finals.
We need to win gold.
Yes.
Marc, thank you.
Yeah. So basically, for me, I think first the fact of being here is, I think, something that I take on board, because I think it shows that people are still interested, are still concerned, and are still willing to push the ball forward. I met, I think, here now a really great presentation. I saw great presentations and got several ideas to dig into or to follow up with some colleagues here. because I think indeed we have our own angles and perspectives, but I think to really approach in such a complex reality as HIV or TB treatments, I think we need a multi-pronged approach, of course, and we need indeed to bring that field experience, that field perspective with academic perspective, with political push and carrots to carry it on. So I think we are bound to work together, and I'm very happy that we are able to agree, sometimes disagree, but the fight must go on, and so let's certainly, I hope, meet again maybe in 1 or 2 years' time to see how far we are gone further and what's the next priority. So I definitely look forward to that.
Thank you, Marc. Pia?
I think I agree with a lot of what you just said. Just organizing this seminar, bringing together this crowd and different perspective has been fantastic. And especially thanks to you coming from South Africa and sharing your experiences here from your community work. That was extremely interesting, and to see how much how far we have come, really, but also to see the remaining challenges on the ground. I think that is what I take with me.
Thank you, Michael.
I guess for me, the take home and really the energizing part is the bringing together of so many ideas for new and different and innovative models of care. And I think as somebody coming from the medical service provision, medical doctor training, as I said earlier, it seems so obvious to do this, but it hasn't been, and it hasn't happened. And so in that sense, it's absolutely critical for HIV/AIDS. But if you really dream, this is the way health services ought to be delivered. So it's incredibly energizing to see this many people coalescing around this idea of using data, working in and with and through communities, and taking the medical model in this new direction.
Thank you. Sibongile?
Oh, sorry, I keep doing that. Yeah.
Unfortunately, I don't have a husband who will tell me that I'm loud. However, I have a lot to take home with. I've learned a lot from this seminar, and I was happy to learn that what other countries are doing, and mostly importantly, the work of MSF. I would like to thank MSF because MSF has supported the work of HIV, from the early age of HIV, especially in South Africa where ARVs were not available, but MSF provided ARVs to South African, especially in Khayelitsha, although it was a little limited number of people, but that meant a lot, and it helped us to learn from that, or it helped the organization like TAC to learn from that few people that MSF was giving medication, and we were able to take up take up our struggle and show the government with evidence that these ARVs what are they doing to people, instead of against what the government was saying, because our Minister of Health by that time was saying ARVs are toxic and they are going to kill a lot of people. Today I'm living, from 2006 I've been taking my ARVs and I'm healthy as ever, and I can do whatever I want to do, of which many people in my country or in my neighborhood, they didn't think I will make it this far. I have 2 kids who are HIV negative today because of ARVs. By that time, if it wasn't for MSF and the ARV, the pilot that they did, I wouldn't have the life that I have today. So by saying so, I will say, I would like to say to MSF, keep up the good work that you are doing, and I will take much from the donor community. I learned more of what is required from us as organization, so for us to be able to access donors. Maybe they'll think up twice about funding organizations like TEC. Thank you.
Thank you very much, Sibongile. I believe that everyone in this room are very grateful as well that you made it. Otherwise, we wouldn't have had the possibility to listen to you today, and I think that was very interesting. Now I give the floor to PehrOlov Pehrson, sorry, too many names today, who's going to give us reflections of the day. Just a few minutes.
This one. Thank you very much. Yeah, it's nice to be the last person of the day, because then you get the last word. I think it has been an excellent presentations. I thank all of you for those. A lot of wise words have been said. I'm old enough to have heard most of it before. That's quite strange. Window of opportunity, we talked about around the year of 2000 or something like that. And all this that bringing treatment, bringing testing and treatment closer to the patient. Yeah, that was on the agenda at the same time. So why has so little happened, in fact? That's a strange thing. The General Director of UNAIDS said that we have what it takes to break the HIV epidemic. We have had it for several years, in fact, and still it hasn't been broken. I think one important thing is what Dr. Johnson said, that the medical profession, which has been taking the lead in a way, taking the lead in handling the HIV infection, is extremely conservative. I have experience from clinical work here in Sweden, where it was a lot of difficulties just trying to make HIV treatment nurse-centered instead of doctor-centered. It took a long time to accept that. I think it's very, very difficult for people to hand over power, because with power goes money, and to leave money from whatever it is, from the central government to the peripheral institutions, to hand over power from doctors to nurses to health workers to lay counselors, it's difficult. It's difficult. You don't hand over power very easily, and I think that has to be recognized. That's one thing. I think it's important with research. We have heard that, a lot of research. But it was not research that brought HIV drugs to gay people in the United States in the 1980s. It was not research that brought harm reduction to IV drug users in 1990s. It was not research that brought HIV drugs to people in poor countries, resource-limited countries in the early years of year 2000. It was activism. It was people who went out in the streets to claim their rights for health care. And I think you have mentioned it from the TAC perspective. I think it has to be recognized that activism is as important as research facts. We have the facts. We need to continue to be active, to have activism. And all of us who want to be activists, we have also to realize that when we take one step forward, sometimes we have to take 2 steps backwards. There will be problems on the way. Marc said it recently, and Anna-Mia also. There will be we have to accept that we will not just go upstairs. We will have to go back sometimes, like Sisyphus, who were trying to push the stone up the hill, but it went back over and over again. And as Albert Camus has said, that you have to imagine Sisyphus happy, and activists must be happy. That's important. You have to send a positive message. We also have to be proactive. We are talking about today's drugs, today's testing methods. In 5 years' time, we will probably have an injectable drug that you just have to give bi-monthly or something like that. That can also be used as a pre-exposure prophylaxis. And today we have to plan for that. How to be activists, to make these new drugs available also to those who need them most, people in resource-poor countries. So go on, continue to be activists. Thank you.